very warm welcome and good evening to one and all. And it is my absolute pleasure to be joining with any program that Pallium India is conducting, because with Pallium India's such structured courses only 5 years ago, I could find out how I can do my clinical services much better than what I was doing 5 years ago. So all that I knew was I'm interested in pain and palliative, but how to provide services, I had no idea. But once I joined Pallium, and there were a lot of guides, there were a lot of experts who were doing it properly and professionally. So I think people who are joining this session also will be joining this network and help in alleviating lots and lots of people's pain and improving quality and make the world a better place to live. So already Madam has told about me, so I don't want to tell more about that. All I do in my clinical practices, though I am a fully practicing anesthetist, half of my work week is divided as every Monday, Wednesday, and Friday, half a day, I practice pain and palliative care. So my OP runs from 2 p.m. to 4 p.m. I see inpatients also. So I admit patients. We have a palliative ward, which is 30-bedded facility, but at a time we generally have 10 to 12 patients only, because we do not have an in-house onco facility. Cancer patients from the neighboring, in our campus, we have a corporate setup also. The cancer patients from there are admitted to our palliative ward. So we do both OP palliation and inpatient care. So whenever there is pain crisis or any other symptom relief required, we admit in our IP ward. So in that way, every day in and day out, we handle patients with cancer pain. And coming to non-cancer pain also, by God's grace and the way my dream, like to integrate non-cancer pain relief also, I am successful in integrating with pulmonology, cardiology, orthopedics, and other general surgery departments, so that any severe pain, any serious health-related suffering, for that matter, people call me, they refer to the palliative ward. For example, in my ward now, I have two patients who are having ischemic pain, like no claudication pain. They have stented their peripheral vessels, but still patient is in pain. Post intervention, they send to us for pain relief, and I give neuropathic pain medications. I run IV infusions of lignocaine or ketamine to reduce pain in the palliative ward. So both cancer and non-cancer pain, we are addressing and we are providing relief. And one more example is chronic pancreatitis pain, where lot of reasons will be there to put multimodal pain analgesia. So such patients also we admit, give pain relief, optimize, and then send back to the surgeons themselves. So that it is why I started with telling this by giving different examples of pain. Is today we are going to start or enter into a world of knowing pain, which is a major disabling symptom in cancer and many other illnesses. If we can understand pain, we can definitely help a lot of patients who are in pain. Pain is not a curse. Even if we can't give complete relief from pain, we can make them functional. We can alleviate their symptoms to a certain extent so that the quality of life is better maintained. Even if their cancer is not treated, they need not die in pain. So, I want to introduce the definition of pain by IASP first. Next slide, SK. So the key objectives are, when we want to know pain and treat pain, we have to talk more about pain. It is our keen observation and clinical knowledge which will come into practice. Like if somebody has fever, you can put a thermometer and see what is the temperature. You need not believe the patient whether he's telling fever or not. But for pain, whatever patient tells is the final thing. When patient tells it pains, it hurts. So the definition of pain itself is in one way that it is so subjective. You cannot measure pain with an algometer or anything. When patient tells it is mild pain, it is mild pain. When patient tells it is moderate, it is moderate. When patient tells it is excruciating, it is excruciating. We take patient's words as such, and we have to keep evaluating. So the key objectives of this session will be the important concept from anatomy and physiology, which is going to help us in evaluating pain or in treating pain. I'm not going to go into depth of anatomy or pain pathways and load you with a lot of information. I'm going to give you very small information which will be needed for us to treat pain or to differentiate a pain, because patient will tell it as one gross pain, but we as a physician should sit and understand to dissect it and understand what pain is he trying to tell to me, what is he trying to communicate to me. Is it a neuropathic pain kind of words he is using? Our language, we should know the local language to understand from the patient what kind of pain is he trying to communicate to me. Is it somatic pain? Is it bone pain? Is it visceral pain? Is it neuropathic pain? We should be able to dissect it. There is no equipment to find out all this. Clinical knowledge and patient listening to the patient is very important. And then the significance of detailed assessment of pain. There are structured way of taking history from a pain patient. As a pain physician, many a times I have given lumbar epidural steroids. Patient will tell pain on the left hand side, but MRI will show right hand side nerves are congested. Right hand side foramen is narrowed. Impingement of nerve is happening on the right hand side. Radiology will tell something different. Patient will tell something different. But whom should we follow? Many times, not many times, almost always we should follow patient only. If patient tells pain on the left hand side, give the steroid injection on the left hand side only. There is something which cannot be detected radiologically. So assessment of pain should be systematic. Entering that into your case sheet is very important, because on day one he would have told pain in one place in one intensity. In day 2, day 3, the pain will be in a different place. So we will have to correlate and make a chain of events to connect what would have happened. Is this cancer spread somewhere? Should I do some other investigation? Should I send him for radiotherapy? All these questions will come if we carefully follow the pain. So history and evaluation is very important to understand and treat pain. The treatment part of it will be coming in the future classes. You will be having detailed classes of the other aspects of pain, treating pain. But in this class, we will focus on mainly history taking and the basic core concept of certain words like allodynia, hyperalgesia, sensitization, and total pain. I want to introduce to it today, because without understanding the concept of total pain, we cannot treat pain. I have separate slides for total pain. This concept, I will tell you, though I was an anesthetist, before I entered into palliative medicine, I never knew about anything called total pain. If we treat only physical pain or biological pain, we will not be successful. We should have the regular habit of assessing the other aspects of pain, like psychological pain, social pain, and spiritual pain. Let us see what it is in the forthcoming slides. So by the end of this lecture or this class, if you are able to know that what is total pain, just by writing morphine, I cannot you cannot wipe away the pain of anybody by just prescribing morphine. It involves a lot of history taking, understanding a patient as a person, not as a patient or as a system or as a diagnosis. We cannot just tell, see a tongue patient, okay, see a gallbladder patient. It doesn't work that way. To see a patient in total only, then only we can prescribe him the right medication, the right thing. So let's go into the details now. Next slide, SK. Pain, we call it the fifth vital sign. Why is it the fifth vital sign? Because now even in nursing registers, people write the pain score every day. In our hospital, after BP, pulse, and temperature, the fifth vital sign recorded is pain. They write the score every day. At least in our ward, it has been really recorded. The score of pain in 1 to 10 scale is recorded. But unfortunately, mostly pain is under-treated. When patient comes to you again and again and tells pain, it is not alleviated with whatever medications you give. After some time, we get fed up and we tell, okay, so everything is in her brain. it is not treated, that patient is simply lying, or her threshold is low, all that we will tell, but we will not try to analyze or dissect the pain further. So it is an undertreated thing. Can we go to the next slide, SK? Let us see how IASP is defining pain. This pain definition, we would all have heard it in theory. What is it telling? An unpleasant sensory emotional experience. We know all that. It is a sensory experience. Pain is a sensory experience. It is going to be subjective. What is it associated with? It is associated with uh, actual tissue damage or potential tissue damage. So if there is actual tissue damage, somehow we can demonstrate it. We can clinically see for Calor, Ruber, and all that. But if we cannot see, that doesn't mean there is no pain. Especially in chronic pain, we may not see any trace of tissue damage, but there will be severe pain. So that is why that clause is in there in the definition, and it is expanded upon by 3 additional keynotes. Here, the keynotes are very important. Can we have the next slide? So the definition doesn't stop here. In 2020, International Association of Study of Pain added the 6 keynotes. Very important 6 keynotes. If we remember these 6 things, we will not ignore pain. We will know how to treat pain in the right way. So pain is always personal experience, which is influenced by biological, pathological, and social factors. What is it like? Many times, social factors, when it comes, we think we are talking some non-medical things. It is somebody else's problem. It is sometimes nurse's problem or some social worker's problem or something like that. No, unless the treating doctor understands the social factors behind, we cannot handle pain. So social factors can cause pain or can worsen pain, can make your make your pain refractory to morphine. So the next one is pain and nociception are different phenomenon. What is nociception? Nociception is just an electrical impulse which travels from the place of pain to the brain through the pain pathways. But pain is what which is perceived in the patient's brain. It is absolutely a sensory phenomenon. It is subjective phenomenon. And through the third point, what they have expanded is through the life experiences, individuals will learn the concept of pain in different way. Certain patients' threshold will be very low for pain. Certain patients will have high threshold of pain. In your medical practice, you would have definitely seen patients who will jump for a small prick also. And some people who will bear with all the suturing you do, they will still silently be lying down. So pain varies from patient to patient. Same tumor, same location might cause different pain in different patients. And then patient's report of an experience of pain should be respected. Never ignore when patient tells pain. Never think she is simply telling. Every day she'll tell pain. It has to be given attention to. The fifth one is pain has an adaptive role. Pain is a protective reflex. When something hurts, we should not go there. That's why pain is there. But what happens when the same acute pain becomes a chronic pain? It starts having all adverse effects of decreased function, social and psychological well-being will be affected for the patient. 1 month, 2 months are 2 months are okay. Continuously, if somebody is in severe pain, how can they be functional? How can you can give advices of do exercise, do physiotherapy, do this, do that. But when they are in excruciating pain, how can we expect them to do function like a normal person? So the adaptive role of pain is only in acute scenarios. When it becomes cancer pain or chronic pain, there is not much of adaptive role. We have to treat pain. We cannot ignore pain. We cannot tell that cancer means pain will be there. Bear with this. This is what some doctors even tell. Cancer pain will be there because they don't have access to morphine or they are not trained to treat. Means they do not refer to the right person. They will tell, okay, some pain will be there, tolerate with it, tolerate. Some severe pain also, some doctors tell to tolerate, but that is a wrong concept. So the last and final one is verbal description is not the only means to express pain. This is a very important concept which we as doctors should remember. If somebody is lying down in ICU on ventilator, can we assume that the patient is sedated and they will not have any pain? they will also have pain. If somebody is in dementia and they are not telling to us obviously that they have pain, but they are on bed and they have a bed sore, is it like we can assume that the bed sore will not have any pain? They will have pain. So we should actively look for pain. When there is a kid who is undergoing treatment, who cannot verbally communicate to you, some deaf and mute people or differently abled people, they cannot communicate to you. So we have to actively look for pain when they are suffering with some serious health related suffering. And when there is some serious disease, we have to look for pain by their facial expressions or the body attitude. There are separate validated scales and means to evaluate such patients' pain also. So this is a very important key concept which I want to be a take home. The 6 keynotes which expands pain, which is defined given by International Association of Study of Pain, has to be kept in mind every time when we treat patients with pain. Okay, so next slide, SK. So coming to the anatomy and physiology of pain, we let us see very briefly. In anatomy of pain pathway, what I want all of us to briefly understand is the pain pathway has 2, like first order, second order, and third order neurons. The red color, what you see is first order neuron from the nociception, point of nociception to the spinal cord. Okay, from the spinal cord to the thalamus, we see that is second order neuron. There is a scope of winding up happening in spinal cord. That is point number 1, which I want to drive home. That wind up phenomenon can happen if we don't treat pain on time. We cannot wait on it until that, okay, if it becomes severe, I will treat. No, it's not like that. We have to treat pain round the clock. We should treat pain when it occurs. If it is mild pain, treat with mild medications. If it is severe pain, treat with severe medications. So wind up phenomenon can happen at this stage. From spinal cord to the second order neuron itself, it can happen. Then one more thing is there is something called gate control theory of pain. So when the fine fibers like C and A delta fibers, which carry pain or carrying in the same way, there are thick big fibers which carry pain, the touch sensation. That is why when somebody pinches or when mosquito bites, we simply rub that area and we get pain relief, right? So never forget that such gate control theory exists. When somebody is in pain, don't hesitate. Put your hand and give them a small rub or massage. Their pain will come down. These things might appear silly to us. We might think, what is my touch going to do to this patient? What is rubbing going to do to this patient? But it might, in the timely manner, it might reduce our analgesic requirement also. So rubbing and giving alternate, even TENS works in that same principle of gate control theory. There are a lot of technological aspects where we can use gate control theory to treat pain. So the other thing is, when you come to the third order neuron, can you see from the thalamus to the cortex, it goes to the cortex, perception happens there. So patients with their experience over years, sometimes we will start ignoring. You buy a new chappal. For one day, you'll feel that the bite of the new chappal. Second day, third day, fourth day. Slowly you get accommodated. So you learn to live with certain pain. So that is where the third order neuron comes in place. So this is how anatomy of pain should come to us in treating the pain. There is the fourth important concept is the right hand side pathway. Can you see both ascending and descending pathway? The blue is a descending pathway. So whenever a noxious stimulus happens and the pain is communicated to the brain, there is also a descending pathway, that is the inhibitory pathway. We have opportunity to activate the inhibitory pathway. Because of the balance between the ascending pathway and the descending pathway only, many times we just ignore some small pains and we are carrying out our daily activities. So we should know how to activate the inhibitory pain pathway also. We have good drugs like NMDA antagonists like ketamine and other drugs which will even tramadol has some kind of NMDA activity, SSRI activity. So NMDA activity, like drugs like magnesium and ketamine, we should make use when we want to activate the inhibitory pathway. So this this knowledge of anatomy of pain pathway is very important to treat pain. So next, let's see the physiology. SK, next slide, SK. So coming to the left hand side, whatever I have told you, can you see from nociception, from the tissue to the spinal cord to the brain, there are multiple levels, multiple drugs are going to act. So local anesthetic will act in the initial place. Can you see opioids are acting in a wide range of places from spinal cord to the brain? So there is more opportunity for us to mix and match our drugs. There is like no only one morphine I'll prescribe next. Morphine is like omnipotent, it will take care of everything. No, it's not like that. Multimodal analgesia is there. Wherever, whichever pathway where you can inhibit, you can use that drug to treat that pain. You can use combination of drugs. So the importance of physiology of pain is when the nociceptor impulse, nociception travels through the spinal cord, the pathway is like transduction, transmission, perception, and modulation. That's what I told. Modulation is happening through the descending pathway. We can use drugs through that also. Perception, as I told, is in the cortex from the limbic system. The thalamus and the limbic system is very much involved in pain. Why is it important? Why should I know that the limbic system and the thalamus are all involved in the pain pathway? Because mood and emotion will affect pain very much negatively. When somebody is happy, an ant bite will be like an ant bite. When somebody is crying and is sad, when they have got a recent diagnosis of cancer told to them, an ant bite will look like an elephant bite. So it will get amplified. When you are sad, pain will be amplified. When you are happy, your threshold to pain will reduce. This is all the neuromodulation happening. All the dopamine, serotonin, norepinephrine, all these neurotransmitters interplay makes all these changes. As a doctor, we should remember this, that we have to use all this to give an optimal solution to the pain of a given patient. Okay, so that's about physiology. Then next, SK, next slide. Next core concept which we should understand is when somebody comes to us with a pain, even in a chronic pain patient, suddenly he would have had a hit on the door, or he would have had a recent fall, and same patient can have both acute and chronic pain. So we should be able to find out from the history immediately. We should ask, is this a new pain? How long are you having this? Did this come now? Even when you see a cancer patient, tomorrow in due course, because you are all in palliative medicine, you'll be handling lot of cancer patients mostly. Such patients will have other coexisting pain also. They might be coming with acute pain also to you. That time we should be able to find out that, oh, I have given morphine, that will take care. Maybe a simple hurt where you can apply diclofenac gel, a simple muscle strain, you can give diclo tablet or diclofenac gel will help. So always we should remember that we should see the pain in analyze the pain nicely, go deep and deep, analyze each segment of pain. What is causing this pain? When is this a new pain? Is this a pre-existing pain? Is my drug inadequate? So continuous evaluation is so important. In that time, when we know that this pain is new pain, we will treat it like an acute pain. So the treatment also will differ from acute to chronic pain. Okay. Next one. Next slide. So classification of pain is very important. That in this one slide, they have given a lot of points, but what I want to drive home here is, can you see in the fifth one, the autonomic response? Acute pain, patient will express, the patient's facial expression will itself tell somebody. They will be holding the hand or they'll be holding the leg. The face will be showing that they are having pain. There'll be tachycardia. All sympathetic response will be activated in acute pain. But in chronic pain, what happens? Patient will tolerate, and they won't look like a pain patient only. They'll come and they'll normally walk and sit in front of you and tell, my pain is severe, doctor. And you cannot think, oh, this patient is not showing any reaction on face. This doesn't look like severe pain. No, we cannot assume like that. Chronic pain patients will may appear very normal to us. They may not have any tachy or hypertension, or they may not even have a facial expression of patients in severe pain. Like, you know how acute appendix patient will look like. You might know how acute cholecystitis patient, they will be bending and they will have guarding, rigidity, everything. But in chronic pain, we might not find. We have to ask the patient, believe the patient that when they tell it's severe pain, it is severe pain in chronic pain. Okay. The rest of the things we can handle later. Next slide, SK. I think these handouts or PDFs will be shared by SK to you. So later on, you can go through these slides for references. So for few slides, I might move little faster. Okay. So next is etiopathological classification. This is one very important slide which is going to help you do your own mental calculation when you're talking to a patient in pain. Okay. So whenever some patient comes and tells pain, it will be a very loose term. When a consultant calls me up and tell, madam, this patient is having back pain and or some pain, and it will be a very loose term. They would not have had enough information of pain, because specialists will see their own specialty in certain manner. But when it comes to pain and palliative specialty, we should dissect pain to utmost level and find out what is the cause of this pain. How can I help for this pain? What else can I do for this pain? So for that, first thing to do is to differentiate between nociceptive pain and neuropathic pain. So the etiological classification is so important. No machine can do this. Only we should do this. So when we know that nociceptors, like, somatic pain or visceral pain, both somatic pain, any muscle, see the skin, subcutaneous tissue, muscle, bone, everything will cause somatic pain. Something in the hollow viscous inside the abdomen, or any visceral organ like angina, gallbladder pain, cholecystitis pain, all this will visceral, hollow viscous, like when intestinal obstruction, intestine is getting distended, it is showing pain. All these are pain, but every pain patient will tell to you in a different manner. For visceral pain, patient will point there only. If I got hurt, somebody stabs me here, here only it will hurt for me. Okay, somebody pinches me, that same point I'll have pain. So somatic pain is very localized. So patient tells this is the area of pain. They can point out with the finger. So that is somatic pain. Even if it is in soft tissue, even if it is a bone, if it metastasis to the bone, they will correctly take their finger and tell, this point is hurting for me. So you can find out that is somatic pain. Visceral pain will be very hazy. They may not point out, say, one single point. They will tell, finally they'll tell whole abdomen is paining. It is dull, it is aching, dull and aching. I can't tell with one finger. So visceral pain has one more additional quality, which we all know, that it can be referred to elsewhere. We all know that angina can be referred to jaw, to the left arm, left shoulder. So that is how we should understand that. Okay, this is visceral pain. This is not the shoulder pain. I should also think about any cardiac thing. If I know, if somebody is telling about shoulder pain, jaw pain, and all, I should have the thought that to rule out other visceral organ pain also. So we should remember that visceral organ pain will be hazily telling. They won't tell one thing. They won't tell it is stabbing, it is pricking. They won't tell these terms. They will tell dull and aching type of terms in their own language. Whatever language they are using, they will tell. In Tamil, they tell for some kodai, some terms they use. Initially, I did not understand. After talking to many patients in this locality, what kind of words do these people use to communicate visceral pain to us? In this area of in Coimbatore area, what are the words people use? So language is very important to take correct history of pain. If you want to really differentiate from this paresthesia and all, if you want to ask, if you have good command of language, you can easily find out. So have some local person nearby when you're taking pain history. Then the next important type of pain is neuropathic pain. Neuropathic pain is Not only when nerve is getting damaged, we'll get neuropathic pain. When something nearby is there, which is compressing the nerve or infiltrating the nerve, also we can get neuropathic pain. So in cancer pain, anything can happen. Cancer can go into the bone also. It can be a somatic pain. It can say one single cancer patient can have somatic pain, visceral pain, or neuropathic pain when nerves are involved. We all know diabetic neuropathy, how it expresses, how it is seen as. Patient will tell paresthesia, burning sensations, tingling, and they tell it in glove and stocking pattern. All this can coexist in a cancer patient also. In any patient, anything can coexist. When somebody comes with one pain to you, do not stop with that. Ask, do you have anywhere else pain? So they will tell. So that time you can start naming the pain, like pain A. Then you write notes about the pain A. You treat pain A. You will have a pain B also, a different entity. It might be due to a different etiology. So your treatment should be accommodating that also. Or you can convince the patient that one after the other I'm going to take care, but I'm going to take care of all this. Then only patient physician trust will develop. So we have to see the pain in toto. All I'm telling is about the biological and physical aspects only. Still, I have not gone to the psychological or social or spiritual dimensions of it. Whatever I'm talking is about neuropathic is also physical parameter only. Okay. So in this thing, the last one small box I have put, no, central and peripheral sympathetically mediated pain. It is a entirely different kind of pain which we do not routinely come across. There is something called neuroplastic pain. It all the things happen in the perception of the brain. So example is like fibromyalgia. Many times patients in fibromyalgia will have allodynia or hyperalgesia and all. The problem is all in perception of pain. With every firing of the neuron, they will perceive it as pain. Every touch also they might perceive it as pain. Normal nociception, not even nociception, normal electrical impulse, normal action potential will finally activate a very wide area in their brains. So chronic pain, we have to always remember that neuroplastic part of pain, central nervous system things can be there. Post stroke pain, no, that also can cause that such kind of pain where you cannot really fit it into nociceptive pain or exactly nerve supplies dermatomal area pain. Like herpes zoster is very much the distribution, this T10 dermatome means only in T10 dermatome. C7 means you see only in C7. But when it goes to central nervous system, when it goes to the third order neuron, then it will be fully like a systemic disease. You have to treat it differently. That is why we have separate questionnaires for fibromyalgia and and entities like that. Okay, and sympathetically mediated pain is another important thing, where when you reduce the sympathetic nervous system, when you treat the when you block the nervous system communicating to the brain continuously, you give a break to it, you break the vicious cycle of pain again and again. The wind up phenomenon will be stopped. So the sympathetic mediation causes the wind up phenomenon into a vicious cycle, and the pain will be augmented multiple times. So in such places, we should remember to use interventional techniques like nerve blocks, or using spinal cord stimulators, or using an anti-epileptic medication or a local anesthesia injection. Such things can block the sympathetic system for a while and give a break to the vicious cycle of augmentation of pain. This is very important in CRPS, chronic regional pain syndrome and all. So this etiopathological classification is very important for us to understand pain and to treat pain. Okay. So next slide, SK. Okay, so I think now we have already covered most of the basics of pain, like anatomy, applied physiology, and the etiopathological classification of pain. Now, looking from a pain perspective, what are the other terms which we should have which we, at least basic terms, which we should know before we treat a patient in severe pain. Okay, so sensitization is a very important concept which we should understand before we treat pain. What is sensitization? It is a neurophysiological response. The pain pathway will become more and more sensitive if left untreated. If you don't intervene and treat pain early, the sensitization phenomenon will happen, and with small stimulus also, the pain will be more. Whatever stimulus previously 5 days ago, for they would have tolerated certain amount of functional ability. With pain worsening, then they will completely become bedridden. So we have to act on time. The nociceptors will be, the threshold of nociception will get lower and lower and lower. Finally, it will become hyperalgesia, or it will become allodynia. What is hyperalgesia? A normal, a painful stimulus will have an exaggerated response. For every painful stimulus, there will be a certain amount of response on day one. You leave it like that, and the brain gets sensitized with continuous pain stimulus. What will happen is exaggerated response will happen after certain days. That is called hyperalgesia. On the other hand, allodynia is different. Like, there is no painful stimulus at all. It is just a touch stimulus, but the patient will be having severe pain. So when a non-painful stimulus is causing pain, it is called allodynia. When a painful stimulus is having an exaggerated response, it is called hyperalgesia. It is important for us to know the difference between two. In centrally nociplastic pain syndromes or entities, definitely we will come across patients telling hyperalgesia and allodynia. Okay, the next slide, SK. Okay, I think this one graph will tell us what is the difference between hyperalgesia and allodynia. When some injury happens, can we see the blue color is a normal pain response, the blue curve. What happens in hyperalgesia is the response is only high, the hyperalgesia. The curve is as tall as normal pain response only, but it is shifted to the left hand side. Okay, but in allodynia, what happens? There is the stimulus intensity is, even if it is very low, even if it is a non-painful stimulus. I had one patient, fibromyalgia patient. For first time when I saw her, she was having a long hair. Next time she cut her hair till her ear. Then I asked what happened. Madam, hair mudi inge shoulder touch panna kuda valikkudu. The hair touching her shoulder is continuously giving pain to her. It is a very normal, it is a non-painful stimulus, right? But it is causing pain to her. So that gives us a clue. Okay, patient has gone into sensitization and allodynia. Now I have to do something about it. I have to escalate my medications, something like that. Okay, so next slide, SK. Okay, now whatever we were talking about, we have put it graphically for us to understand. The two basic types of pain are neuropathic pain and nociceptive pain. These are basic types of pain, which everyone will come across. Nociplastic pain is what? Or neuroplastic or nociplastic. Anything with plastic means it is not defined. It you know what, how plastic, no, plastic can take any shape. You heat it, it can become into any shape, it will change shapes. So that is why nociplastic pain, we do not know how all it will, for what all stimulus it will become painful, what all areas in brain are getting stimulated. Each patients will have different kind of trigger response. Some patients will tell, when I when I sit to eat only, I get pain. When some patients will tell, when I lie down only, it happens. So the stimulus, normal stimulus, will become painful for them. So the examples are fibromyalgia for nociplastic, and some kind of not all migraine. Migraine can go into continuously, if we don't treat it, nociplastic situation can develop. You can see on the right hand side, for neuropathic pain, carpal tunnel, herpes zoster and all is given. And for nociceptive, see, like arthritis pain, ulcers, pain due to wound, everything is given. But we should not forget that the other side, they have given psychological, social and cultural aspects should be remembered to treat pain in toto. That is a big circle around. Okay, the big circle which encloses all three circles is that we should never forget the socio-cultural aspects of pain. Okay, next slide, SK. Okay, next is a very important topic which is going to help us day in and day out when we are going to treat cancer patients. Cancer pain is not a single entity. Cancer pain does not get treated with just one drug. Cancer pain has to be seen in a different way. That is the difference between a pain and palliative specialist treating a cancer pain and the rest of the other people who are not trained in this specialty treating pain. Okay, so what are the components of cancer pain? We should always ask this pain. Not every cancer patient should have pain. The incidence is 9 to 80% of cancer patients will have pain. Towards the end of life, almost 70 to 80%, most of the patient, at least once in their lifetime, cancer patients, I'm talking about cancer patients, once in their lifetime, at least they'll have severe pain. So what should we do about it is we have to understand this pain is caused by the cancer per se or the cancer invading which anatomical part is causing this pain. What can we do about it? The treatment of cancer itself will relieve it most of the times. Then there can be complications due to cancer as a disease. Because of cancer, I have lost weight, I've got, I can't eat, emaciated, and then I'm lying down on bed for quite some time. Then we are prone to develop complications of cancers like sores, DVT or lymphedema. These entities separately can cause pain. So a cancer patient need not always have pain due to cancer. The lymphedema, breast cancer is a painless blood breast lump, we all know. But when lymphedema occurs, that is painful. So we have to be treating lymphedema in its own manner. We cannot do a blanket treatment for all cancer patients. CA breast is such a pain, when the lump comes, it is not going to be painful. But when the axillary nodes come, they tell pain there. When post-surgery or post-radiotherapy lymphedema happens, there is pain there. So we should be able to dissect the cause of pain in a cancer patient. The next thing is chemotherapy-related pain. Most of the times, chemotherapy-related pain will be small nerves neuropathic pain. So we should know how to treat neuropathic pain in cancer patients. Sometimes just because of that, the infusion has gone and extravasation of chemotherapy agent there will be local induration, local pain response will be there. So we should know how to treat that also. Though that chemical phlebitis can be really a big suffering for the patients. So we have to address the right thing in the right way. Then radiation-induced pain. Radiation-induced pain, many people get headaches. For some brain tumor patients and all, they get headache post-radiation. So we should know how to treat that also. Most of the times, the oncologists themselves, the radiation oncologists themselves will give prophylactically medications for such pains. And mucositis is one common thing which we will see. Most of the times we start with oral examinations in cancer patients for such reasons only. Because of this mucositis, generally immunity is down and mucositis and candida infection, or because of radiation therapy, mucositis and immunity reduced and candida infection. All this will be very painful. Because of this one single reason, cancer patients will not be swallowing food. Why konnume pudikala, they can't eat, they tell I can't taste anything, I can't swallow, it is painful. If a simple intervention of treating the oral candidiasis and treating the oral mucositis with the appropriate anti-inflammatory drugs and anti-infective drugs will do major improvement in their suffering, in such patients' suffering. Okay. And then comorbid conditions. As I told you, cancer patients can, if the cancer patient is diabetic, he can have peripheral neuropathy. He can have a burning sensation in glove and stocking pattern. So we should not be close-minded. We should ask other symptoms also. If somebody is having coronary artery disease along with cancer, they can have angina. We should be systematically treating the cancer pain separately, angina separately. We should encompass and we should give a holistic care. The same patient Many patients, old age patients, will have arthritis. So we should be able to give something either orally, or systemic therapy, or local therapy, physical therapy, to handle their arthritis also. So we should see the person in toto, not cancer as a disease separately. So cancer pain is as such, like, multidimensional. Cancer pain is not a single concept. It includes so many other things. We have to see the person and the cancer in total. Okay. So next slide, SK. Okay. So when we treat pain, we need to know these important terms. There is something called baseline pain and breakthrough pain or incident pain. When we understand these concepts only, we can treat cancer pain in the right way. We will be generally writing morphine. We all know that morphine acts for 4 to 6 hours only. So Q4 hourly, you write morphine. But sometimes patient tells when they are dressing up, or when they are moving them from the bed, or when they are putting the when they're giving bedpan, when they are doing cleaning procedures, only patient has pain. In that time, we call that as incident pain. When patient is moving or is given a bedpan, for such time we can be more prepared for that. During that time only, morning dose you can increase. So knowing these things, knowing it is background pain or it is breakthrough pain, we can treat it better. And breakthrough pain is a pain which is severe pain, a peak which is occurring there is a standard pain, cancer pain, which is happening. Standard intensity of pain, we measure it in 0 to 10 scale. Somebody is having 5 score of pain always because of some tumor, say some tumor in the mandible. At some point of time only, in the night only, there is some breakthrough pain. So what we should do is, we should have some leeway, or we should have some dosage given to the patient in addition. Keep this at home, one tablet extra. Whenever you get a breakthrough, whenever a severe pain occurs, you can take this SOS medication. So the prescription principles vary. So we do not write only routine medication. We write routine medication. Along with routine medication, we write an SOS tablet. That is to address this breakthrough pain. Patient should not feel helpless and hopeless after going home. Oh, doctor told 6 a.m., 10 a.m., 2 p.m. and 6 p.m., 10 p.m. What will I do in between if I get severe pain? So you have to put a SOS medication also if they are going to get breakthrough pain. Okay. So incident pain also is considered as breakthrough pain. You can always tell them that, okay, when you are moving from bed to wheelchair only you are having pain, no? Whenever you are bathing only you are having pain, no? Okay, morning activities are more, so let us add one more tablet in the morning. Or some patients tell, daytime I'm managing, doctor, night only is a problem. Night only, when I lie down supine only, I have all the problems, especially patients with vertebral meds. They will tell, night time only I have pain, doctor. Daytime somehow I'm managing, I can't lie down. So night time we can keep one SOS extra, so that the control is given to the patient also. So much of teaching learning will happen between patient and us, so that you give the control to the patient or to the attender. Whenever the patient, you give this, you can give to the attender, or you can tell to the, give me a minute, I'm getting a phone call simultaneously. Just excuse me for a minute. Okay, I think we are good to go. Okay, can you hear me now? Yes, SK, you are able to. Okay, okay. So
yes, we can hear you.
Thank you, ma'am. So the concept of background pain, breakthrough pain, and incident pain is so important when we are prescribing opioids. Okay, then let's next slide, SK. Okay, the final and very important thing, which is very unique to the specialty of palliative medicine, is total pain. I should tell you one truth, that I was treating pain even before I did a palliative medicine course. But after understanding this total concept of pain only, I am really treating the patient. Patient satisfaction level will be extremely high if you apply the concept of total pain. And Another thing is you cannot treat cancer pain. Even the other back pain and other pains you can somehow treat. But cancer pain, if we want to treat, you should know the total pain concept. Any chronic pain for that matter. Nowadays, I'm applying these concepts to treat even chronic pancreatitic patients, somebody who's alcoholic, even non-cancer patients. Also, I'm using the same concept. Not only me, every one of us should use a total pain concept. This is very, very important. So from in one corner lies the physical pain, the biological aspect of pain, that as a physician, we can handle it. We not always we can handle it, but we can address it at least. But there are unaddressed aspects of pain, which is hidden inside a patient, inside a person. We see them as a system or as a diagnosis or as a patient, we will miss this. If we see them as a person, if we try to connect to them as a person, in 20 minutes we can get the history of all these things. It comes by practice. Many times we will think it looks like more non-medical stuff. It is not. That is all wrong. When you can see some seasoned palliative physicians taking history, in 15 to 20 minutes they'll come to know what are all is happening beyond the patient's visible appearance, and they will plan addressing all these things. Okay, so this is based on Maslow's hierarchy of needs. Physical needs are there for a human being, psychological needs are there, social needs are there, and spiritual needs are there. This Maslow's hierarchy is very well established in psychology. These needs have to be addressed for any human being. So more so for a patient in serious health related suffering, any cancer or end stage renal failure, end stage cardiac patient, anybody for that matter who is in severe pain or in suffering. So all this total pain, we should understand that it is all interlinked. When somebody, for example, same diagnosis, everything is same cancer, two different patients. One patient has continuously some attender taking care of them. Family support is extremely good. Morning, elder son is taking care. Evening, younger son is taking care. Wife is around. Wife has support. Economically, they are better. This patient and one more patient B, consider patient B, his economical status is poor. He has two daughters to get married. Still, they are not earning. He is the only earning member. Same tumor, same diagnosis, same stage of tumor. Both are same age. Whom do you think pain will be more? Both are having some pain. Definitely patient B will be having pain more. The social pain is added to them. Some kind of unfinished thing will be there for the patient B. So definitely we should explore the social aspects and psychological aspects. There is one important thing called relationship between chronic pain and depression. They generally go hand in hand. Like patients in fibromyalgia or even herpes zoster patients for that matter, they will go into depression because chronically they're having pain. They are considered, their functional ability comes down. They will miss out all social, they can't go to marriage, they can't be mingling with everyone, they can't do any social activities. So chronic pain patients you have to rule out depression in chronic pain patients. Same way, depression patients will come up with some or the other somatoform disorder like pain complaints. So we should know to differentiate between these two. We should know, as a pain physician, we should know to use the questionnaires for depression in palliative patients, so that we can treat depression when it becomes clinically significant. We need not, like a psychiatrist, we need not treat depression, but we should be able to identify depression and send a call for right help. Like, when psychiatrist has to be involved, or a psychologist or a counselor has to be involved, we should be involving them. Okay, so psychological pain is very, very significant. We have to understand that depression coexists. Whenever the diagnosis cancer is given itself, some patients will go into depression. When somebody with low back pain, bedridden for 3 months, they will go into depression. So we have to rule out clinical depression. We should take professional help for this. We should involve psychologists, counselors. We should always think about multidisciplinary approach to pain management. The final thing is spiritual pain. This concept I never knew before, but after this palliative medicine thing only, I understood what is spiritual pain. Many patients, after getting the diagnosis of cancer, they will come to the question of why me? Why did I get this? Why did this happen to me? One non-smoker, non-alcoholic yoga teacher got coronary artery disease and CABG. So every time I go to the rounds, he will ask, Doctor, I am the cleanest of the being. I have no bad habits. Look at my body habitus. I'm looking so, no, so healthy, very muscular. I do yoga every day. I teach yoga to everyone every day. Why did I get coronary artery disease? So this kind of why me question will be there, especially in acute stages. Unless we answer that or we address that, even if we don't know the answer, we should explore that. The basic quality is we will not have an answer to every of patient's question. We should at least explore and acknowledge that certain thing happens or exists in a patient. So sometimes when we get professional help, we can easily handle that. Uh, we may not have solution to every problem. We may not have a solution to financial problem. We may not have solution to spiritual problem. Some people will be in guilt, especially CA lung patient. Many times I've seen COPD and CA lung patients, they'll have guilt because I smoked only, I got this, no. So family is now hating me, they are keeping me in a separate room. Many times COPD coexists with TB, they will be alone. TB will be, secluded and kept. Many times family will think cancer like TB, they will keep the patient in separate room. They will be dying of guilt. Guilt will worsen the pain. So just writing morphine will not be enough. We have to explore what is the reason behind their suffering. Once we explore it, it will slowly dissolve, and it will come to a point where we can involve the right help in your multidisciplinary team, and you can address that. Once they know that somebody is standing behind me, many of the pain, many of the problems will come to a manageable level. Okay, so this is a very important concept which we should know when we are treating pain, especially severe pain. Okay, next slide, SK. I think my time is nearing. So from SK, how long do I have? I have few more, 10 more slides, I think.
Another 5 minutes or something. You're nearly touching the hour, Punitha.
Okay,
so if you could just, because we have a case presentation also,
yes.
Max is 5-10 minutes because we have to have some discussion also. 5 minutes,
Okay.
can you wind up, please?
Yes, I can wind up. So I will touch on all these slides only. You can go back and explore more
because
about
we
it.
will share the slide also. You just go through them so that, okay? Is that okay?
Yes, yeah, that's fine, ma'am. I'll do that. So when we know we are going to handle some pain patient, we have to systematically assess. This is this Socrates pain assessment or PQRST. Anyone. My favorite is that Socrates because it comes easily. Where is your pain? When did it occur? How is it? So it comes naturally to me. So I have chosen Socrates. So it is your choice, but use some way of systematic assessment of pain. Just beating around the bush, you will miss something or the other. So we won't clinch the diagnosis. So use some systematic assessment methods like this questionnaire. Okay. Next slide, SK. So this is how we start assessing pain. So when we are assessing pain, we have pain scores like 0 to 10, linear scale. What we should understand is for every age group, there is different pain score. This table tells that for pediatrics, there is a different pain scale. Next slide, SK. Okay, this is the commonest pain scale which we would have all seen. So up is a numerical pain scale. 5 is moderate pain, 10 is a worst pain imaginable, and 0 is no pain. Most commonly, we all use this NRS only. We'll ask how is a pain. When illiterate people, how many paisa out of 1 rupee? They will tell 50 paisa, 60 paisa. Then you can convert it to NRS and rate. For children and other people, you can use this phase scale also. Okay. So this is very important. We should not hesitate to use this. Unless we use this, we will not be able to track the response of your drug or your intervention, whatever you have done. You have given a drug or you have done some intervention. You have to track the improvement. No, so this is very important. You have to note down in your case sheet. Next slide, SK. the same thing what I told. Visual analog is just in millimeter we will be measuring. So 100 mm will be there. So it comes like percentage only. It is almost one and the same. Next slide, SK. Okay, so the first three things are very simple scales. This has to be regularly used. This flag scale is for pediatrics by seeing the face, like posture, activity of the child, cry of the child, and the consolability. We can score the pain. We can give pain score for children also. Even if they don't talk, we can give pain score. Next slide, SK. So you should be aware that flag scale is used for pediatric. Then pain-AD scale is for dementia. There are many other scales for dementia, but the common ones I have given example. Pain-AD scale also has the same things, like you can see, no? How is breathing, how is they are groaning, moaning and all will come in negative vocalization. How is the facial expression? How is the body language and consolability? Something like flag scale, but for dementia, elderly people, we have a separate scale. That is called pain-AD. Next slide, SK. So we should not hesitate to use these scales when we get such a patient. When you get a dementia patient, we should take out the scale. You can just download on the net and you can start filling that. Then there are multidimensional pain scales also. They will have questionnaires about psychological, social and other aspects. Okay. So we will not miss this depression and all. So that is what is multidimensional pain scales are all these four McGill's commonest used is BPI. We use BPI. In our pain clinic, we have the short BPI scale. So we will tick as the patient tells, we will tick this questionnaire. Fibromyalgia has a separate questionnaire. DN4 is for neuropathic pain. Okay. We should slowly, we should make it a habit of using these questionnaires. Okay. Next slide, SK. All these things are available in the internet. You can see I have put the brief pain inventory. The left hand side is brief pain inventory. Right hand side is McGill pain questionnaire. So when you just go through, these are very simple to use also. There is a body chart in it. No, the body chart is very important. You should have in your case sheet, there should be a body chart seal or this thing so that you can mark pain A, radiation, pain B and all. You can mark the pain. You can shade the areas of severe pain and all. Which is light pain, which is severe pain, all that you can mark. That is very important aspect to use to know to use a body chart is very important. Next slide, SK. Okay, this is DN4 questionnaire. This is for neuropathic pain. So as the score increases, you know that the neuropathic pain is worsening. It is out of 10 again. And it also has the same simple things like paresthesia, tingling, all these things will be there. So you just tick and you find out, okay, score is more than 5, then this can be a neuropathic pain. Okay. And you can track the response to your drug. You have started pregabalin for somebody. You have started nortriptyline for somebody. Then you can track your pain with the DN4. These are all validated scores. Okay. DN4 is a validated questionnaire. Next slide, SK. So how DN4 is for neuropathic pain? For this neuroplastic, nociplastic pain syndromes, like fibromyalgia, separate questionnaires are there. So you have to use that questionnaire and see, will they fit into fibromyalgia definition? Okay, this is just this will be dealt in non-cancer pain by somebody else. But this is just to tell you that when you have to evaluate pain, evaluate in the right way. Use the right questionnaire. Okay, next slide, SK. Okay, this is the final slide, I think. So this is the take home. We should evaluate patient in total. We have to do evaluation in all these aspects, and that nearby colored circle, it gives how to ask for this history, how to ask for spiritual history. There are some separate scoring systems for everything, social, spiritual, pain and all, how to ask. Okay. I think this is the last slide. Next slide, SK. Let me see. Okay, there is one more 30 number slide is very important. Can you go to that, SK? Number 30 slide. No, forward, SK. Yeah, next one. Yeah, this one. So what we should understand is, can you see the barriers of pain relief? How clinician contribute to poor pain control is we are preoccupied with the diagnosis, underlying diagnosis, getting the next diagnosis, let immunohistochemistry come, let this come, let that come. Until then, you keep pain in waiting to get treated. No, it should not be like that. You start treating pain, get your diagnosis, hand in hand. Diagnosis should not stop for pain. Pain should not stop for diagnosis. Both should go hand in hand. Okay. So next one is preoccupation with other patients. Means we find no time to attend to pain patients because they need lot of time to attend to. An underestimation of pain severity is one common barrier. Fear of side effects, sedation, fear, opiophobia is a main barrier. And then suspicion of patients abuse and misuse. Yes, this is very much in India. And failure to ask patient about pain. Sometimes this happens. Unless asked, sometimes some patients won't tell also. And then how patients contribute to poor pain control is they themselves will think, I have a disease, I have to bear with pain. So they won't even know that options are there, solutions are there. They won't tell us. So that is stoicism. The next is poor self-reporting of pain. The same thing. They don't tell to you that they have pain. Fear of being accused of drug seeking. This happens many a times. It's okay, doctor, I will adjust. Sometimes some patients tell that. Then unaware of available analgesia. They don't even know the solution exists. So they keep the problem persistent within themselves. So these are the barriers to adequate pain relief. This we have to be aware of. Okay. Then I think I'll wind up with this. So the take home is pain should be approached in total. Thank you.
Thank you very much, Dr. Punitha. Really, I think it's this introduction to pain is not a simple one, because only if you know this background, because generally, this anatomy, what she said, anatomy, physiology, all of you would have read in your first year of whatever you study. But only in the last few years, like last 10, 15 years, there's something called as focal MRI. So which has opened up the whole world to what it is. Not only Punitha, don't think that she's been told. The whole world, science has opened up, because in the last 20 years, these MRI studies have shown, they see active MRI blood flow in patients who are experiencing all this. So only from those studies, this pain concept has developed so much. And the next thing is that the definition, the old definition was said in 1979. Then in 2020, the whole definition was changed by ISP. Okay, so these are very, very salient factors and features. And this nociception, neuropathic, and one more thing, neuroplasticity. See, neuroplasticity is just like, simple way, one path is there from point A to point B. Now, all of you know Google. Google will show you 4 paths. One path may be in a ditch. One path may not be. But like that, our brain is also capable. So they see a lot of positivity in that neuroplasticity also. See, the neuroplasticity is what is causing all the problem. Okay, it is just not taking one path. See, it can respond in one way. It can respond like collaterals. These are all nothing new. Everything which we have known in medicine, collateral, ectopic, then additional, like upregulation, downregulation, all what you've studied in other systems are possible in the central nervous system too. So these are concepts which you have to understand. So that is neuroplasticity. Taking other, it need not obey or happen or do a function in one particular way. It can function in different ways, like a naughty child. See, so many things you can take. It can, any child can behave normally, no? It can behave naughty also. So the same thing happens in the central nervous system. So really just taken you all through. So that is the concept. If you have this, then you will treat. Okay. So this session is going to be the basis. You're going to have, there was a query, how to give, what prescription. What she told you today, like dose, prescription, you will have completely one session on how to, whether your prescription is right. If you don't write this, your prescription is incorrect. Like that, you will have session. That is why I did not answer to that chat box question. You will have a detailed session on how your prescription should be. If your prescription is complete, if you're not writing SOS, or if you're not writing PRN, if you're not writing breakthrough, if you're not writing ABCD, your prescription is incomplete. All that will be dealt. And this neuropathic, nociceptive, everything, if you know only, you will treat. applied pharmacology. If you don't know what you have to do, you won't be able to do it. So if someone is having nociceptive pain and a neuropathic pain, so now you will go say, no, one medicine not enough. You're not treating the neuropathy. So like that, all that you will have individual sessions. So anybody has any questions, please unmute and ask. I'm just checking the chat box if anything else. And someone who has missed out the initial half an hour, we will share the prescription. Sorry, I am in my doctor mode. Prescription. Okay, we'll share the PPT. You will all be able to do. Okay. I think anything else anybody wants, please. Otherwise, we'll go on to the case discussion, I think. Is that okay? Thank you very, very much, Punitha. Very appropriate and what was required you have done. Thank you very much. Yes, Sangeet, we can go on to. Does anyone want to ask anything? I just heard a voice. Okay, then Sangeet, let us go on to the case presentation.
Okay. So today's case presenter is Dr. Suma Samuel. Welcome, ma'am. Out to you, ma'am.
Sir, okay, thank you. Am I audible?
Yes, ma'am, you're audible.
Okay, thank you. So today's case is about...
Slightly your voice is low, dear. Can you come close to the mic or something? Or are you using headphones?
No, I'm using a earphone. Should I take that off?
No. Just make sure you're speaking on it because your volume was slightly low. That's all.
Okay, fine. So this is about a 58-year-old male patient who came to our OPD, and the final diagnosis is squamous cell carcinoma. But Mr. SK, if you could just go to the second slide. Yeah. So the patient came with severe constant throbbing pain, and this was in relation to the lower right back teeth, and he's had it since a week. And when the pain started, he opened his mouth and he noticed that there was a growth across his lower posterior teeth. About a day later, he was unable to eat any solid food and he was just consuming semi-solid and liquid food. And very soon the pain extended from the teeth right down the right side of his neck. He had some painkillers which were prescribed from a local hospital, but he obtained no relief. And since 2 days, he has not been able to sleep at all. So this is again going into the history. 1 week back, the patient had slight intermittent pain only across his right back teeth. But very soon it became very severe, constant and throbbing. And when he opened his mouth, he noticed the growth across those teeth. And a day later, he stopped having solid food because he couldn't chew. He consulted a local hospital and he was prescribed painkillers, but that did not give him any relief. And 2 days ago, the pain exacerbated even more and he couldn't sleep at all. By then, the pain had already extended to the right side of his neck as well. So extraorally, we saw that there was a large growth in the right submandibular region, around 2 into 2 centimeters in size, nearly round and extremely tender. But the patient did not even allow us to touch the area because he was in excruciating pain. So coming to intraorally, there was an irregular ulceroproliferative growth, approximately 3 into 3 centimeters in size, which was extending across the buccal sulcus and the buccal gums or gingivae of the right mandibular last 2 molars. The growth was also extending posterior to the teeth into the retromolar area and medially towards the lingual gingivae of the teeth and the floor of the mouth. The right last 2 teeth, molars, they were slightly mobile and the growth bled mildly on palpation. The patient was extremely uncomfortable due to the severe pain during the examination. He was also very exhausted. There weren't any pressure sores as such for this patient. So when we took an X-ray of OPG, it showed that there was severe bone loss on the last two teeth, and the teeth were floating because of lack of bone support. The patient was immediately admitted in the ward because there was nothing he could do otherwise, and he was prescribed IV antibiotics, IV fluids, as well as iron analgesics. He was also given tramadol to control the pain. I haven't mentioned that here. And after 2 days, once the pain and the discomfort reduced, an incision biopsy was done, and the biopsy report was suggestive of poorly differentiated squamous cell carcinoma. The patient was, after this, referred to a nearby cancer center for further treatment. Coming to the psychosocial aspects, the patient was working outdoors as a rubber tree tapper. He was a lone breadwinner of his family, and he has a wife and 2 children. He was anxious and desperate and wanted to know if this was a malignancy. And if it was, he preferred to leave for home with painkillers and didn't want any other treatment. His main concern was the severe pain and the sleep deprivation. In addition to that, once he was unable to work, he was also worried that he would be a financial burden to his family, as well as the cost of treatment, and also after his time, how the family would cope later. So coming to the summary, a 58-year-old male patient complained of severe constant pain in his right mandibular molar since 1 week, and with the growth, and he was on analgesics, but it did not improve. The pain continued. He was unable to eat solid food since 6 days. The pain gradually extended to the right side of his neck, and it has kept him awake since the last 2 days. On examination, there's an extraoral enlargement in the right submandibular region, roughly 2 into 2 centimeters in size, nearly round and extremely tender. No other examination is possible. Intraorally, there was an irregular ulcer proliferative growth, approximately 3 into 3 centimeters in size, extending across the buccal sulcus and the buccal gingivae of the last molar teeth, which were also mobile. And the growth also extended posteriorly across the retromolar area and medially towards the floor of the mouth and lingual gingiva. It was also bleeding mildly on palpation. The patient was in severe pain and exhausted. OPG showed floating teeth as well as severe bone loss. The patient was admitted in the ward, given IV antibiotics, IV fluids, and iron analgesics. And a biopsy was done, where the report came as poorly differentiated squamous cell carcinoma. He was later referred to a nearby cancer center for further treatment. Ma'am, may I read out the discussion points too?
Yes, please. Yes, go ahead.
Yes, ma'am. So the first point that I wondered about this patient was how could we help the patient to understand and accept his diagnosis? He is almost sure that it's a malignancy, but how do we work towards making him understand and accept it in a positive way? I don't know if the word I use is appropriate, positive.
Okay. Next
See,
one.
like you just read them and we'll deal with them one by one. You just read all of them.
Okay. The next question is about pain evaluation and on will focus.
Okay, number 2, okay, how can we explain to the patient that pain relief alone is not a practical approach, so that the patient will accept the treatment modalities of malignancy, that is surgery, chemo, and radiotherapy, because all he wanted was a painkiller and just the pain to go away so he could go back to work and continue taking care of his family. The third point was what are the holistic approaches to his fears of being a dependent and financial burden, as well as about the emotional support to his family through and probably even after his time is over, through his treatment as well as later. And the last point is how his remaining life could have quality, dignity, as well as peace of mind.
Thank you very much. And Punitha, you can go ahead and just the thing, no, like we have a topic on communication as such, in which you will be dealing with your first discussion point. Because the rest maybe you can take her through, Punitha, then I will also add on. I think just first one I thought of telling because it's a topic on its own.
Yes. Even first one and even fourth one also. It's
exactly.
Quality.
So you just touch and whatever you can, and then we'll round up.
Sure, ma'am. So actually, it was a very good case selection and case presentation, Dr. Suma. You have done a very good job of making that summary also. It is very impressive to see that you have addressed it step by step. So I can add few points where we will refine it further. Okay, the first question, as ma'am told, breaking bad news is a topic by itself which we can talk for a whole day. So you will learn it, and being from Pallium India, I can proudly tell that they will handhold you how I am here today from my day 5 years ago. How for every single thing I used to call Pallium India, I used to call Radha ma'am if I'm having some difficulty, any Sunil sir, Sri Devi ma'am, everyone I'll bombard them with phone calls only. But we will definitely be beside you to help. These are very big things, breaking bad news and ensuring quality of life, dignity and peace of mind and all. It is not a simple task. It needs a multidisciplinary team. You should have, people have chaplaincy in their team, right? So the same way, we will be having a counselor, a social worker, a physiotherapist, on all specialty doctors will come. And once if you see the MDT meeting happening in Pallium, then you will understand that, okay, I single-handedly cannot handle this. So we as human beings are social animals. We have to be, in groups only we can function. We cannot do it in a single-handed manner. For your first and fourth question, that is answered. So definitely, but we can address all these things, and it is all doable only. And coming to your second question is about pain. About pain, let us see. One good thing you have told us how to make the patient understand that treating pain is not enough. We have to treat the disease also. So as I told you, both should go hand in hand. The moment you start giving pain, you have given pain relief, the depression will come down, the trust will come on you. Then they'll start listening to you. So it will take 1 or 2 weeks time for them to listen to you, to take them to the treatment. Okay, now that you are comfortable, let us find out the best way nearby where you can go for the next test, next surgery, or next evaluation for the surgery, or next radiotherapy, or we can book an appointment for your radiotherapy. With this, you will also have a network, right? You will know oncologist, you'll know radiotherapist, or your institution might have one, and you can link them with social workers where they can find the affordable places where this patient can go. So clearly he is a single breadwinner, and there are financial constraints, so we have to guide them that. But at the moment, addressing the pain is more important to develop trust on you and your system. So once the patient is relieved of pain, they will follow our other advices also. And coming to pain per se, you have nicely told about the details of the lesion and all. What I would like is, I showed you the Socrates, the site of pain, how was onset. Clearly, it is acute. But what was missing was the quality of pain. And with X-ray, we know that bone invasion is there. There is no severity which we have assessed, because we have to assess severity so that day one, how much did you have? 5. So the progression you can know. Within 1 week, this is so progressive. From 5 score pain has become 10 score pain in 2 days. Then you will be more alert. Okay. The quickness with which we will act will be more. So severity has to be documented. And if it was a body chart, you can put in from next session onwards, the other speakers can make sure they put a body chart, mark the pain with A, B, and C. Pain A. Now you told it's in the neck. So neck is having lot of nerves also around. Brachial plexus is there, cervical nerves are coming out. So is there any neuropathic pain added to it or no. If it is only here, there might not be any neuropathic pain. Facial nerve is very much there, but is it affected? Is it any shocking sensation on and off, coming and going? All that you could have added. And other things, other aggravating relieving factors you have already told. With sleep is not there. That itself tells that it is severity is like more than 8. The important thing you have captured is he is telling I'm not able to sleep because of the pain. That means he qualifies for strong opioids. You know the WHO ladder, right? So now straight away no tramadol, only morphine. And one more thing is you told it is very tender and it is ulceroproliferative. Now we should dissect the pain. Oral cavity is having full of flora. Infection will be there. Good thing is you have already put antibiotics. It's very right thing to do. Inflammatory component will be there. Anti-inflammatory you have put, but you should continue. Just because morphine is added, anti-inflammatory need not be stopped unless until you see those things, inflammation come down. You told it is swollen and tender. So continue anti-inflammatory, and especially when you told that in the X-ray or OPG, bone involvement is used tooth are there, right? Because bone is involved. When bone pain is involved, you have to think of powerful anti-inflammatory like a steroid, like a dexamethasone. So the component of my prescription would be primary anchor will be morphine, but along because it is severe pain. It is something more than 8. Patient is not sleeping. So morphine along what is making this pain refractory to tramadol and other thing is continuity would not have been there. They would have stopped. Now once you write morphine, you should tell until you come to me next time, you cannot stop. You have to go by the clock, by the mouth, you can continue it by the ladder. So morphine will be the anchor. Along with that, anti-inflammatories and antibiotics will be going on. And by your history, I don't see neuropathic pain as such, but you should be watchful for that in future. And one more important thing with my personal experience of what I've seen is oral hygiene. This patient was so exhausted, you told, right? So opening mouth was also difficult. I'm sure he would not have brushed his teeth, fearing of pain. So that will lead to more and more infection. Dental area is where infection prone area, no? Oral cavity is. So we should teach them the simple homemade oral hygienes. Like in Pallium, they teach how to make small half cup of water with a pinch of salt and with pinch of soda, no? Baking soda, cooking soda they put, and then to rinse the mouth at least twice a day or thrice a day, so that the oral flora is maintained and it doesn't contribute. Some edema will reduce, inflammation, pain will reduce, infection also will reduce. And if there is anaerobic infection, Metrogyl wash can be given. That will also reduce pain. When we reduce inflammation with this kind of oral hygiene techniques, if there is candidiasis, if you see a coating, but your patient is just 1 week history only, 1 or 2 week history. So he would not have gone to that much immunosuppression and oral candidiasis level. But in oral cancers, we should remember that it very many times, all these anaerobic infections and candidiasis is a common cause of pain and foul smelling discharges. So that has to be kept in mind in due course. But currently, to your history, I don't think it will add value. But oral hygiene matters. So according pain relief, we can give in this manner. Once pain relief is obtained, this patient will slowly, you can hold his hand and take him for further investigations and treatment and surgery and all. I think your third question is holistic approach of financial, that's the same thing. It needs a multidisciplinary team. One man cannot do everything. We are part of a team. So, but it is very important to explore. Simply asking the patient a question that how much can you offer? Can you do this first? Or can you afford this treatment first? This can you do? When you are having a normal human interaction, unlike a doctor-patient relationship, no? Then they themselves will come up with solutions. Nobody, caretaker is not there, then somebody will tell, okay, one sister living there is there. She may come and live with me for 2 weeks, madam. Somebody is willing to help from my side. They might help for this time, madam. And they will come up with solutions. So if we just available for them open-mindedly, and our team people, like especially a medical social worker or a counselor is guiding, many solutions will be born, like cancer pensions they can write to the government for cancer pensions, something like that. They will know the nearby NGOs who are helping. So we have to involve the right person for a holistic thing. And the moment we relieve pain and they know that simply you are standing nearby them, you are there, whatever happens, that holistic care will automatically come. They won't feel abandoned. Even if we don't cure, they won't feel abandoned. So this is what even evaluation of pain should be much more better. Next time onwards, the body charting and scoring of pain in numerical rating scale people can do, because this being your first or second session, I know I was also in this place not assessing. We do not know the right way to assess pain, so we should use the proper scales and body charts and tell the quality. Remember to ask for the quality of pain so that we can add appropriate medication. That is it from my
Thank
side.
you, Punitha. The
Something.
thing is that as just the scoring, I was also about to tell that, because you, and one few things what I wanted to add is, see, Dr. Punitha has shown you various options. You tailor make to your practice what will work for you. Okay, that's why we give, see, nearly 10 slides of assessment things she told. Okay, so there are so many things. Use something. See, your patients maybe can't read, so use body chart. Someone well educated, then you tailor make or use of all what was shown today, use which will work for you. Okay, so that is one thing. And then assessment first, then you give some treatment, reassess, use the same chart. For example, body chart, use red color first time, then blue color second time, orange color third time. So one chart you can use as assessment, and review will give you the outcome of your treatment also. So that is something I wanted to add on. And then this treatment options, no, you will have 4 more sessions. WHO ladder, everything will be covered later, Punitha, next, as you are aware. No? So you will know all that depending on what level of pain and everything. And then next is multimodal. Like first session I told you, multimodal approach, multidisciplinary management. One thing again I'm adding, not that don't have any failure feeling, guilt feeling, I cannot do everything. No need to do. Like team working. Okay, there's no I in team. TEAM is the spelling for team. Okay, so work together, learn to work together. So especially as she said, when all of you get the opportunity to come, wherever nowadays, that's how it happens. You'll have a psychologist or psycho-oncologist with you, and you will have a physiotherapist. You need to have a social worker, because I may not know what all government schemes are there. And if I don't know, should the patient lose everything? No. If you have a social worker, they will guide you. And then there are so many NGOs willing to help. The patient is struggling here. You just find a bridge between both of them. Connect the demand to the supply. So these are things which you will all learn in due course. So basic thing for a palliative care service is one doctor, nurse, if possible, one social worker. That is the bare minimum. Then you can add on physiotherapist and psychologist. So social worker is your right hand. Nurse, or one can be nurse right hand, social worker left hand, or nurse left hand, social worker. So these are essential. So only with all that you can go. And then here, because it's the first session, someone as our social worker is who? There are people who, there are so MSW. That is a social worker, because someone had asked who is social worker. Rakesh Umashakar. They basically who have done MSW course. And there are people, most of the units do have. Pallium has like 8 or 10 people. When I used to work in Adyar Cancer Institute also, we had. So normally all institutions have, because only then, see, now total pain, no, social has one component that also has to be dealt. So you will read, you will have a session on psychology, psycho-oncology, like psychosocial issues, what are important. So entirely, as Punitha said, this is a whole structured one. You will cover everything. Okay. So the pain element, once you treat the pain, you will know that the patient themselves will open up. They are thinking it cannot be cured, cannot be done anything. So just when, as anesthetists, we always say, when you subside the pain, no, everything opens up, new world will come up. Okay, and then next is always working together as a team will help you. And when you have to tell them, once the pain subsides, you can tell about various forms of treatment options available. Then you have to do a full assessment, what staging of the disease. Then we have to be open. Then, as I said, that will come in communication. What to tell, how much to tell, when to tell. And then based on that, you make goals of care. Okay? Yeah. As I told first day, I'm not going to break the beauty and expertise of each session in one session itself. Okay, so you'll all have to enjoy every session.
That's true.
That is important.
Yeah.
So that's all. So I think with that, I've seen the chat box also. Nothing have left. I think a big thank you to Dr. Punitha. As she said, we have known each other for quite some time now, and amazing job you did, and telling it in the way what they need. That is the most important. Hope all of you would have also enjoyed. It will be very useful and practical when you all start seeing patients. Okay. Yeah. Thank you very much, and over to you, Sangeet. Anybody else? Is there anybody else having any burning question, want to unmute and ask? Please do. Otherwise, we can wind down for today.
Writing, you will come to know how much morphine to write, how to add text.
No, they have a session next. Second, third session will be entirely on it, Punitha.
On it. Yeah.
No worries. 5 sessions you're going to have, like including this, you'll have 5 sessions,
and,
5 or 6 for pain itself.
India's website has a very good resource of, I think, ma'am, in resources section, we have opioid prescription, like Twycross, one book is there. One whole book is online available in Pallium India website.
See, that website has got so much information. All of you, please look into that whenever you have time. So much of information.
Whenever I have doubts in prescribing oral morphine or any opioid changing, opioid rotation, just go back to Twycross. Textbook is there in Pallium India website in resources section. Just go online, it is available. The whole book is available. 48 pages or something. If you read that, you'll know how to prescribe morphine orally.
So much information is there in Pallium India website. Yes. Use it.
Yes, madam, myself, Dr. Jayasudha, madam. I want to know what are the schemes available from the government? What help does the government give for cancer patients? Because I'm working for railways, and it will be useful to give this information to
what I'll do is I'll ask Sangeet to connect you to the social worker department there. Okay, because that is what will be. As I said, no, I told you I may not be an expert in it. So there is a big social and the community department in Pallium. Sangeet, may I know your name, please?
Ma'am, my name is Dr. Jayasudha, ma'am. Because today morning I was struggling to help a patient with ALL who was needing some help.
Railway hospital, where are you?
Perambur, madam. Perambur Railway Hospital.
No worries. Railway Hospital and Cancer Institute they used to be good ties.
Yes, ma'am.
Anything and everything will be done.
There. Yes,
no worries. What I'll do, Sangeet, is John still there?
John has moved to the facilitation department, ma'am.
Then connect John to her, because John is from Tamil Nadu, or at least connect this doctor. Doctor, can you do one personal message to Sangeet, please?
Yes, ma'am, definitely. I will, ma'am.
So get her connected to the concerned department, and then you question them and you ask what all you want. Okay?
Sure. Yes.
That is what. Who is willing to? Where there's a will, there is a way. If you ask, you will get.
Yes, ma'am. Okay. Thank you.
Thank you, Sangeeta. I'll pass it on to you.
Thank you, ma'am. Thank you, Dr. Punithavathy, for the wonderful session. Thank you, Radha ma'am, for facilitating the entire session and clearing the doubts for the participants. Thank you all for participating very actively in these sessions. Thank you all. I have shared the link in the WhatsApp group for the resources material. You can refer it from that group. Okay, thank you all. See you in the next session. Bye.
Okay, bye-bye.
Good luck to one and all.
See you, ma'am.
Thank you, dear.